Laparoscopic left hemicolectomy with inferior mesenteric vein sparing, a step-by-step surgical approach. We have no disclosures. A 64-year-old male presented with a change in bowel habits for 6 months. After investigation, a well-differentiated adenocarcinoma of the distal transverse colon was found, with no evidence of distant metastasis. In this case, we decided to perform a laparoscopic extended left hemicolectomy, with IMV sparing. Here is the CAT scan for this case. The patient was placed in the supine position, and the port placement is shown in the picture. The tumor in the mid to distal transverse colon was identified. We started the operation with left side colonic mobilization using a medial to lateral approach. The dissection was performed following the plane below the superior rectal artery and the plane below the inferior mesenteric vein. After identifying the root of the IMA, we skeletonized it from the root until the left colic artery was clearly identified. The left colic artery was controlled using a sealing device. Next is the IMV sparing technique. We found that if we control the IMV with high ligation, the venous drainage of the sigmoid colon might be affected. In our technique, we preserve the main branch of the IMV and ligate the small branches that drain into it, to ensure good venous drainage. After identifying the IMV, we carefully dissect it along this vessel, aiming to skeletonize it and remove all surrounding fatty tissue. The branch that drains into the main IMV was identified and ligated. After that, we enter the lesser sac. In this step, you will clearly see the main branch of the IMV. Lateral mobilization was performed until the previous dissection plane from the medial side was reached. The root of the middle colic vessel was identified, and controlled. The transverse colon was fully mobilized. Then, a small vertical incision was made. Colonic resection was performed, followed by a total hand-sewn end-to-end anastomosis. This is the specimen from this case. The patient was discharged without perioperative complications. A colonoscopy was performed at 6 months postoperatively, revealing no evidence of anastomotic congestion or stricture. Thank you for watching.